Audible. Audible. This one.
No, no, we.
Good afternoon, sir. Audible. Sir, start ಮಾಡ sir. Hello. Sir, start ಮಾಡ sir. Start ಮಾಡ sir. It's not clear. Welcome to the. ಸರಿಯಾಗಿ ಕೇಳಿಸ್ತಿಲ್ಲ. ಸರ್ Arun, 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 not at all like audible. Not at all audible.
Hello, I think 2-3
ಸರಿ ಸರಿ. See, it's coming so late. Sari is raising hand.
You, when you want to talk to sir, you have to talk use this. That's why instead of that, we put a collar mic. Better than this.
Sir, good afternoon, sir. Sir. Good afternoon, sir. Good afternoon, sir. Sir. Sir, start ಮಾಡಲ sir.
Hello.
It's getting very late. ಮಾತಾಡಿದ ಯಾವಾಗಲೂ ಕೇಳಿಸ್ತಿದೆ.
No, you talk. It is coming now.
Good afternoon, sir. Sir, start ಮಾಡಲ್ಲ sir.
खाली सर परमिशन
Sir.
सर परमिशन ಕೇಳಿ
हाँ sir. So ಏನಪ್ಪ sir start ಮಾಡಲ್ಲ sir. हाँ ಕೇಳಿದ್ದೀನಿ. ಏನಪ್ಪ sir ಈಗ?
ಅವರ ಮರೆ
Good afternoon, sir. ಸರ್ ಅದು ನಾಳೆ CM ಗೆ ಅಂತ ಇದು ಟೆಸ್ಟ್ ಮಾಡ್ತಿದ್ದಾರೆ ಸರ್, ಹಾಗಾಗಿ ಒಂದು ಸ್ವಲ್ಪ ಸರಿಯಾಗಿಲ್ಲ ಸರ್. ಮಾಡ್ತೀನಿ ಸರ್, ಸ್ಟಾರ್ಟ್ ಮಾಡಲ್ಲ ಸರ್? ಹಾ ಸರ್, ಓಕೆ ಸರ್, ಓಕೆ ಸರ್, ಓಕೆ ಸರ್, ಥ್ಯಾಂಕ್ಸ್. Keep the source. Sir, good afternoon, sir.
Sir, anybody else is speaking? Yeah.
Calcium metabolism and osteoporosis. Coming to introduction, calcium is indispensable to life. Calcium is the most abundant cation in the human body. Total amount of calcium in the body is around, in infants it is 28 to 30 gram, adult male 1200 gram, and adult female 1120 grams. 99% is present in skeletal tissue in the form of inorganic complexes and about 4 to 5 grams in striated muscles. 20 to 350 milligram in the blood, mainly in the plasma. In plasma, it is mainly in three forms: ionized form, free form, complexes with organic elements. Here is a chart which shows the concentration of calcium in the body. Maximum is free, that is ionized form of calcium, it is about 50%. Then comes to protein bond, it is about 40%. The main protein which bond is albumin. And about 10% is complex with anions, citrate, bicarbonates, lactate, and phosphates. Here is a brief explanation about the composition of the bone.
Hello.
Bone is mainly composed of organic components and inorganic components. In inorganic components, like it is around 70%, in which 95% is hydroxyapatite, and 5% there are the traces sodium, potassium, magnesium, and fluoride. In organic components, about 2% is the cells, that is osteoblasts, osteocytes, and osteoclasts, and matrix, that is 98%. In an adult of average 60 kg weight, 1 kg is the composition of the calcium, of which 99% present in the skeleton and 1% in plasma and extracellular fluids. In skeletals, 99% is non-exchangeable and 1% is exchangeable. In plasma, which is like 1% of that, ultrafiltrable is 50% and protein bond is 47%. As I said, the main protein bond is albumin, which is around 37%, and 10% it is bond to globulin. Daily requirement of calcium in normal individual is,
Hello.
in adult man and woman, it is 500 to 1000 milligram per day. In infants, 500 to 600 milligram per day, and in children of age 1 to 9 years, it is 400 to 500 milligram per day. And 10 to 15 years, it is 600 to 700 milligram per day. Pregnant women needs a more calcium. So daily per day. Sources of calcium. The best source of calcium is from milk, eggs, తెలుస్తుందా? Cheapest sources includes green leafy vegetables, cereals, and millets. Other sources should be mentioned is beans, soya beans, and potatoes. Drinking water may provide up to 200 milligram per day of the calcium. The best sources, as I said, they are fish, egg, milk, and green leafy vegetables. Absorption of the calcium. Calcium absorption across the intestinal wall occurs in the two major mechanisms, that is active transport, that is transcellularly, and passive, that is paracellularly. Active transport of the calcium is dependent on the action of calcitriol and the intestinal vitamin D receptors. Passive diffusion and paracellular uptake involves the movement of calcium between mucosal cells and is dependent on the luminal serosal electrochemical gradient. Factors decreasing the calcium absorption include long-chain saturated fatty acids, that is palmitic acid, as it forms the insoluble calcium soap, and phytic acid, oxalic acid, caffeine, and corticosteroids decreases the calcium absorption. Role of parathyroid hormone. Parathyroid hormone is 84 amino acid polypeptide secretion chief cells, secreted by the chief cells. The normal level of parathyroid hormone is 10 to 60 picogram per ml, and its half-life is 2 to 4 minutes. Its serum level is controlled by a negative feedback. Parathyroid hormone maintains the plasma ionized calcium level via three mechanisms like osteolysis, that is by increasing the number and activity of the osteoclast as well as the transport. It increases the proximal renal tubular reabsorption of the calcium, increases the activity of an alpha hydroxylase. Calcitonin, it is 32 amino acid polypeptide. It is secreted by parafollicular cells, the C cells of the thyroid gland. Actions. It diminishes the osteolytic activity, inhibition of jejunal absorption of the calcium, inhibition of tubular reabsorption and promotion of urinary excretion calcium. It inhibits the 1-alpha hydroxylase activity. Dietary factors affecting the calcium absorption, that is enhancers. The factors which enhance the calcium absorption are like acidic medium. It increases the solubility of the calcium salts, bile salts. It emulsifies the ingested fat, results in increased absorption of the vitamin D. Need for calcium and animal protein. Factors which inhibits the calcium absorption are slowly fermentable fibers, that is hemicellulose, oxalate, chelate, calcium, magnesium, phosphorus, rapid motility, diseases of bowel such as sewer and tuberculosis. Calcium absorption from supplements various dependence upon the salts, calcium carbonates, acetates, calcium lactate, calcium citrate, and calcium gluconate. Losses of the calcium from the body. Renal, it loses about 250 millimole of calcium per day are filtered at glomerulus. 98% is reabsorbed and 65% occurs in proximal convoluted tubule and remaining fraction progressively along with the nephron. Only 10% of calcium desorption that occur in distal nephron has been shown to be subjected to hormonal regulation, principally by parathyroid hormone. Normal range of urine calcium is 1 to 7.5 millimole per 24 hours, as assessed by Sulkovich test. Sulkovich test is done by mixing the 5 ml of urine with 5 drops of 1% acetic acid with 5 ml of potassium oxalate. If there is no precipitation, it signifies the hypocalcemia, that is less than 7.5 ml per dl. If it is free cloudy precipitate, then it is 9 to 11 milligram per dl. And if it is heavy precipitate, then it signifies the hypercalcemia. Factors that increase the renal tubular absorption are hypovolemia, alkalosis, and thiazide diuretics. Factors that decreases the renal reabsorption are volume expansion, acidosis, high protein, loop diuretics. Extrarenal losses. Calcium is secreted in almost all body fluids, but maximum through digestive juice in GIT, that is about 150 to 300 milligram, and very small amount occur in sweat. Functions of calcium. Calcium forms the major part of the bones, and it takes part in the formation and resorption of the bones. It helps in blood coagulation, causes neuromuscular excitation, transmission of the nerve impulses, cellular adhesion, maintenance and functions of cell membrane. It takes part in activation of certain enzymes as well. Helps in synthesis of nucleic acid and proteins. Regulation of the calcium in the body. Plasma calcium concentration is principally controlled by parathyroid hormone, that is 125 hydroxyvitamin D, calcitonin, and other hormones. Parathyroid hormone is secreted by the parathyroid gland. It on three target organs, that is bone, enhanced increased calcium concentration in blood by action on the osteoblasts. Kidney causes increased tubular resorption of the calcium and excretion of the phosphorus, and also increases the synthesis of 125 dihydroxycholecalciferol. In intestine, indirectly it increases the intestinal absorption of the calcium via its effect on vitamin D synthesis. Coming to disorders of calcium, hypocalcemia, it is decrease in level of the calcium. A corrected serum calcium concentration less than 2.2 millimole per liter, or an ionized calcium concentration less than 1.2 millimole per liter. Causes for hypocalcemia are vitamin D deficiency or target organ resistance, liver diseases, deficiency in diet, renal failure, and drugs like anticonvulsants, parathyroid hormone deficiency or target organ resistance, hyperphosphatemia, loss of calcium from the circulation, that is excessive chelation. Features of hypocalcemia. Mild hypocalcemia may be asymptomatic.
Hello.
Sir?
Sorry.
Sir?
Yeah, go ahead, go ahead.
Yes, sir. Thank you. Chronic hypocalcemia may present with mild diffuse brain disease, mimicking depression, dementia, or psychosis, cataract and calcification of the basal ganglia. Severe hypocalcemia, that is calcium level less than 0.75 millimole per liter. Tetany, as it develops in severe hypocalcemia when it's usually associated with alkalosis. Tetany is characterized by paresthesia, particularly around the mouth, lips, and tongue, and muscle spasm, particularly of the hands, feet, and face. Severe hypercalcemia can also occasionally cause cardiac arrhythmias and heart block. An ECG typically shows prolonged QT intervals. Latent neuromuscular instability can be elicited by Chuvastek's sign and Troisius sign. Chuvastek's sign, it is a twitching of the muscle innervated by the facial nerve. It is done by tapping the facial nerve over about 2 centimeter anterior to the external auditory meatus. When this nerve stimulates, it shows ipsilateral contraction of the muscles supplied by the facial nerve. Troisius sign, it is done by using the BPR spikomanometer, increasing the systolic pressure for 3 minutes. It gives the characteristic appearance at flexion at the wrist, flexion at metacarpopharyngeal joints, extension at interphalangeal joint, and adduction at the thumb finger. Vitamin treatment. Vitamin D3 0.5 to 2 microgram per day and elemental calcium 1 to 2 gram per day in divided doses. And diuretics and IV 10% calcium gluconate can be given. Coming to hypercalcemia, A corrected serum calcium concentration more than 2.6 millimole per liter, ionized calcium concentration of more than 1.3 millimole per liter. Hypercalcemia is common and dangerous in the elderly. Causes for the hypercalcemia are parathyroid hormone related. Causes related to the parathyroid hormone are primary or secondary hyperparathyroidism, ectopic parathyroid hormone secretion, vitamin D related, vitamin D toxicity. Granulomatous diseases, excess of vitamin D3 production. Malignancy, increased osteoclastic activity due to bone destruction by primary or metastatic tumor. Drugs like diuretics, lithium, vitamin A and its analogs. Endocrine disorders like thyrotoxicosis, adenocortical insufficiency. Features of hypercalcemia. Usually, mild hypercalcemia is asymptomatic, but affected patient may have hypertension, muscular weakness, and irritability. Mild gastrointestinal disturbance, renal colic, bone cyst, impaired renal function, that is polyuria may occur, and decreased bone mass. Hypercalciuria and nephrolithiasis may occur. Bone lesions, subperiosteal bone resorption of the hand, and salt and pepper-like appearance of the skull can be observed radiologically. Patients with primary hyperparathyroidism usually lose cortical bone mass in the appendicular skin. Treatment for hypercalcemia depends on the cause, rapidity of the calcium rise, and serum calcium levels. Treatment includes rehydration, diuretics, calcitonin, steroids like prednisolone, non-steroidal anti-inflammatory drugs, and hemodialysis. Mentioning the rickets here, rickets can be defined as disease of infancy and childhood, which results from the poor mineralization of growing bones before epiphysis. Epiphyses are fused due to disturbance in calcium and phosphate metabolism. And osteomalacia, it is due to decrease and defective mineralization seen in adults and is similar to rickets in children. It is characterized by softening of the bones and accumulation of osteoid tissue. Coming to osteoporosis, it is mainly seen in the elderly age group, especially among the post-menopausal women. It is characterized by abnormal reduction in the bone tissue mass per unit volume of the anatomical bone. That is, quantitative bone is diminished, but qualitative bone remains same. Quality of the remains doesn't change. Osteoporosis defined as progressive systemic skeletal disease characterized with low bone mass. Its characteristics resembles with osteopenia. Age-related decrease in the bone mass secondary to uncoupling of the osteoclast and osteoblast activity. It is due to this, it causes disrupted microarchitecture of the bone. Coming to epidemiology, male to female ratio is 1:4, and a higher prevalence of secondary osteoporosis 60%. Male due to hypogonadism, glucocorticoid excess, and alcoholism. Osteoporosis, postmenopausal osteoporosis is highest in women aged 50 to 70 years. Senile osteoporosis is one which begins after 70 years. Secondary osteoporosis may begin at any time. Fracture wrist occur most commonly at the age of 50 to 60 years due to osteoporosis, and vertebral fracture may occur most commonly at the age of between the age of 60 to 70 years, and this fracture occur most commonly at the age of 70 to 80 years. But the fracture which is most common is the vertebral body more than the hip and wrist fracture. Mentioning the constituents of the bone, bone contains many inorganic and organic constituents, as I mentioned. Risk factors for osteoporosis. Lifestyle, sedentary lifestyle, smokers, low body weight, low protein intake, heavy drinkers, positive family history, premature menopause, breastfeeders with low vitamin D. Genetic polymorphism, calcitonin receptors, estrogen receptor 1, type 1 collagen alpha 1 chain, Osteogenesis imperfecta in adults, vitamin D receptors, low density lipoprotein receptor related protein. Diseases which may cause osteoporosis are malabsorption syndromes, liver diseases, hyperthyroidism, type 1 diabetic mellitus, cancer, chronic renal failure, COPD, and rheumatoid arthritis. Coming to pathophysiology, quantitative, it is osteoporosis is quantitative, not qualitative. Disorders of the bone mineralization. Factor to build the peak bone mass as engaged. Bone loss in the later life. Associated condition, fragility fractures. Direct relationship between the degree of the bone loss and the fracture. Kyphotic deformity can arise from the vertebral body fractures. Pelvic pelvic ring insufficiency fracture, most often treated with bed rest and analgesia.
I want to know now.
Sir? Sorry, sir. Hello. Sir. Totally orthoplasty with
Let the speakers be anywhere.
I can.
Both should not end the meeting.
Share, sir. Share. I think we have changed the
fractures. Associated with 15% increase vertebral fracture associated with increased morbidity.
No, sorry.
Back pain, loss of height, poor balance, respiratory compromise, that is restrictive lung diseases and pneumonia. History of one vertebral fracture results in 5-fold increased risk of second vertebral fracture and 5-fold increased risk of hip fracture in patients with osteoporosis. History of two vertebral fractures is strongly suggest indicated for further compression fracture in post-menopausal women. Hip fracture associated with 20% increase in mortality. Men have higher mortality rates following hip fracture than women. Associated with increased morbidity, reduced quality of the life. Only 1/3 of the patients with hip fracture return to their previous level of the functions. History of one hip fracture results in up to 10-fold increase in risk of the second hip fracture. FRAX score. WHO fracture risk assessment tool that calculated the 10-year risk of hip fracture and 10-year risk of major osteoporosis related fractures. Factors includes age, sex, personal history of the patient, low BMI, oral steroid use, secondary osteoporosis, parental history of hip fracture, smoking status, and alcohol intake. FRAX index. WHO criteria for clinical diagnosis of osteoporosis. It's T score. If it is normal, it is 1 or greater. In osteopenia, it is in between -1 to -2.5. Osteoporosis, it is -2.5 or less. And severe osteoporosis, it is 2.4 loss and fragility of the fracture. Classification of osteoporosis. It's Nordin's classification and Riggers and Melton's classification. Coming to Nordin's classification, it is generalized and localized. In generalized, it is primary and secondary. When it is localized, it is diffuse osteoporosis, Sudex osteodystrophy, transient osteoporosis, regional migratory osteoporosis, idiopathic chondrolysis of the hip. Riggers and Melton's classification. It is primary. Type 1, it has type 1 and type 2. Type 1 is mainly for the postmenopausal and type 2 is for senile. Age group postmenopausal, that is highest incidence of 50 to 7-year-old. That is, and bone affected is almost exclusively trabeculae. And bone which get fracture most commonly is distal radius and vertebra. Net negative changes in the calcium level because of the decreased intestinal absorption and increased urinary excretion of the calcium. Type 2. It is more than senile, that is more than occurring more than 70-year-old. The bone most commonly involved is trabecular more than cortical. Bone fracture Bone fracture. Bone fracture is 1 second. Notes it, that's it. Bone fracture is hip and pelvis, poor calcium and absorption. It's not working.
No.
Go ahead. Go ahead.
Secondary osteoporosis, that is causes of secondary osteoporosis. It may be nutritional or inflammatory. The nutritional causes may be due to malabsorption, malnutrition, and scurvy.
Yeah.
And inflammatory disorders which may cause secondary osteoporosis are rheumatoid arthritis.
It's coming well. Sometimes video on means that network issue will be there.
Network is the main thing.
But this is okay.
Sir. But video, oh, it's there.
No, no, no.
Ankylosing spondylitis and tuberculosis. Clinical features of osteoporosis: chronic low backache, progressive loss of height associated with vertebral deformities, appearance of thoracic kyphosis, that is Dowager's lump, which is specifically seen in osteoporosis, approximation of rib margins to the iliac crest, patient appears older than his or her age, history of the fracture. Clinical manifestations of osteoporosis, that is general. Fracture occur after bending, lifting, or falling. That is, fracture may occur due to small trauma or insignificant trauma. And the symptoms that are pain, immobility, bruising, depression, and lower self-esteem. Coming to signs: shortened stature, kyphosis or lordosis, bone pain or fracture, commonly of vertebral or hip or forearm. Investigations for osteoporosis, we have to get all the things like CBC with ESR, serum calcium, phosphate, and albumin, renal function test, plain X-ray of the hip, thoracolumbar spine, parathyroid hormone if serum calcium is higher, that is more than 10.5 milligram percent. Coming to imaging, radiograph. Indications are suspicious of the fracture, loss of height, pain, thoracic or lumbar spine. Recommended views for osteoporosis are lateral spine radiography and epipelvis or hip. Radiological findings, that is vertebra, you can see codfish appearance, codfish vertebra, tight concave appearance of the vertebral body, thinned cortices, loss of trabecular bone, kyphosis. Specific investigations include plain radiograph of thoracolumbar spine and hip. Index radiological grades are grade 1, principal compression of trabeculae markedly reduced in numbers, and grade 2, compressive trabeculae can be seen. In grade 3, break in continuity of the principal tensile trabeculae. Grade 4, principal tensile trabeculae reduced in numbers, but still can be traced from lateral cortex to femoral neck. In grade 5, principal tensile and compressive trabeculae accentuated, quadrangle prominent. In grade 6, all normal trabecular group visible, proximal end of the femur completely occupied by cancellous bone. This index is not usually helpful unless the bone loss is more than 30%. This is DEXA scan, that is dual energy X-ray absorptiometry. It usually performs in lumbar spine, measures bone mass from L2 to bone mass density from L2 to L4 and compiles score. Hip. It measures as bone mass density from femoral neck, trochanter, and intertrochanteric region and compiles score. Most accurate and least radiation exposure. BMD, that is bone mass density, is its absolute patient specific score determined from certain anatomical areas. T score is bone mass density relative to normal young match controls, that is 30-year-old women. Z score. Z score is bone mass density related to similar age patients. Osteopenia. Osteopenia is L2, L4 lumbar density of 1 to 2.5 standard of deviation. T score minus 1 to minus 2.5 below the peak bone mass of a 25-year-old individual. Osteoporosis. In osteoporosis, L2 to L4 lumbar density is more than 2.5 standard, 5 of the standard deviation. The T score less than minus 2.5 below the peak bone mass of 35-year-old individual. Quantitative ultrasound. This is the quantitative ultrasound, which contains the calf support, strap, position of ultrasound, water field membrane. Advantages is like low cost than DXA, portability, no radiation exposure. Studies we need for the osteoporosis are biopsy. Biopsy to be given after tetracycline labeling. Its indication is helpful to rule out the osteomalacia. Histology, thin trabeculae, decreased osteon size, enlarged Haversian and marrow spaces, osteoclast ruffled border, increased osteoclast ruffled border seen with parathyroid hormone, 125 dihydroxy vitamin D3, prostaglandin E, latent ruffled border seen with biphosphonates and calcitonin. Osteoporosis and osteomalacia. Continue, madam. Osteoporosis is bone mass normal mineralization. What are you doing? It's working now. Reduce size. What happened? Difference between osteoporosis and osteomalacia. Osteoporosis is reduced bone mass, that is with normal mineralization, but osteomalacia bone mass is variable and reduced mineralization. Age most common with osteoporosis is postmenopausal, that is type 1, and elderly, type 2. Osteomalacia can occur at any age. Etiology, endocrine abnormalities, age, idiopathic inactivity, alcoholism, and calcium deficiency may cause osteoporosis. When it comes to osteomalacia, vitamin D deficiency and or abnormal vitamin D pathway, hypophosphatemia, hypophosphatasia, renal tubular acidosis. Symptoms and signs. In osteoporosis, pain and tenderness at the fracture sites are most common, but in osteomalacia, generalized bone pain and tenderness can be seen. In X-ray, axial fracture predominates, but in osteomalacia, appendicular fracture and predominance, symmetric includes pseudo fracture, that is loser's zone. Osteoporosis will be normal, but in osteomalacia, it will be decreased. Serum phosphate level is normal in osteoporosis, and osteomalacia, it may be low or normal. Iron phosphatase is normal in osteoporosis, but is decreasingly elevated in osteomalacia, except osteomalacia associated with hypophosphatasia. Urinary calcium. Urinary calcium. It may be high or normal in osteomalacia, but is normal or low in osteomalacia, but it may be high or normal in osteoporosis. Bone biopsy can be done in osteoporosis with tetracycline labeling normal, but in osteomalacia, tetracycline labeling will be abnormal. Coming to the treatment part, for osteoporosis, it is non-operative and operative. In non-operative, the main thing is lifestyle modification and vitamin supplementation. For non-operative, the indication is calcium and vitamin. In pharmacological treatment, indications: 2008 National Osteoporosis Foundation guideline for pharmacological treatment of the osteoporosis suggests that pharmacologic treatment be considered for the postmenopausal women and women for more than 50 year of old, for more than 50 year of age with hip or vertebral fractures. T-score between -1 to -2.5 at the femoral neck or spine. 10-year risk of hip fracture more than 3%, 10-year risk of major osteoporosis related fracture more than 20% by Frax calculation. T-score -2.5 or less at the femoral neck or spine. Pharmacological agents which are used in osteoporosis are mainly calcium and vitamin D, biphosphonates, conjugated estrogen, progestin hormone replacement therapy, that is HRT, estrogen only replacement, salmon calcitonin, cortical or mecalcin, raloxifene, and teriparatide. Mentioning the operative procedure for the osteoporosis, one of these things is like osteoporotic vertebral compression fracture, femoral neck fracture, and distal radius fracture are the indication. In pharmacological treatment of osteoporosis, anti-resorptive drugs, that is biphosphonates, selective estrogen receptor modulators, hormonal replacement therapy, calcitonin, and denosumab. Biphosphonates are the first-line treatment, first-line therapy. Indications are hip or vertebral fracture. T-score less than -2.5 at the femoral neck or spine after exclusion of secondary cause. Low bone mass, that is T-score between -1 and -2.5. Mechanism of action of biphosphonates is it inhibits osteoclast resorption. Coming to classification, biphosphonates is of like first generation, second generation, and third generation. Etidronate, telodronate are the first generation biphosphonate. Second generation, pamidronate, alendronate, and ibandronate. Coming to third generation, they are risidronate and solidronate. Mentioning the dosage, alendronate, the dosage is 5 to 10 milligram OD or 35 to 70 milligram weekly. Pamidronate IV infusion should be given, that is 60 to 90 milligram over 2 to 4 hours weekly or monthly. Residronate monthly 75 milligram on 2 consecutive days every month or 5 milligram daily dose. Ibadronate quarterly IV 3 milligram as infusion or 2.5 milligram once daily or 150 milligram once monthly dose. Zilodronate, that is 5 milligram diluted in 100 ml saline and glucose solution. Here are the drugs and indications and their effects that are used in osteoporosis. That is drug like calcium and vitamin D. The main indication is prophylactic, that is in all patients, best for the type 2, that is elderly patients. Its effect is calcium reduces the fracture risk by 34%, vitamin D. Vitamin D supplementation reduces the hip fracture risk by 10% and non-vertebral fracture risk by 7%. High dose vitamin D reduces the hip fracture by 24% and non-vertebral fracture by 30%. Daily calcium and vitamin D requirements are as follows. Age 1 to 3 year, 500 milligram per day. 4 to 8 year, 800 milligram per day. 9 to 18 years, it is 1000 to 1500 milligram per day. Age more than 150 years, it is 1200 to 1500 milligram per day. Non-nitrogenous containing the biphosphonate, that if indication is T-score less than -2.5 standard deviation, fragility fracture of the hip in both men and women. Its mechanism is produces toxic ATP analogs. Here are the drugs: etidronate, clodronate, and telodronate. Conjugated estrogen progestin hormonal replacement, that is HRT. It's indicated in the women with type 1, that is within 6 years of menopause. Characteristics are decrease the risk of hip fracture, but it also led to a small increase in the women's risk for the breast cancer, heart attack, stroke, DVT, and Alzheimer's disease. Its adverse effects are combined estrogen and progesterone therapy are risk of breast cancer, myocardial infarction, stroke, estrogen alone, risk for the stroke and venous thromboembolic events. In estrogen only therapy, it is mainly indicated in the women with prior hysterectomy. Its characteristics are like estrogen receptors are present on the osteoblast and osteoclast. Taking unconjugated estrogen, it increases the risk of endometrial hyperplasia or uterine cancer. Testosterone, it's indicated in the men with low level of testosterone. Its character is it's not yet approved by FDA for osteoporosis. Coming to the next, salmon calcitonin, it's indicated mainly in the women more than 5 years postmenopausal, decreases the pain in acute vertebral compression fracture. It acts as a neurotransmitter. Its mechanism of action is it binds with the membrane receptors on osteoclasts to inhibit the resorption. Injection may be given or nasal spray, but it destroys the gastric acid. Intranasal transient rhinitis, injectable nausea, vomiting, flushing, and hypersensitivity are its adverse effects. Raloxifene, that is Evista. Its mechanism of action is it acts as an agonist on estrogen receptors in bone as it reduces the osteoclast reabsorption, antagonizes the estrogen receptor in the breast, reducing breast cancer risk. Selectively estrogen receptors modulate, that is slow bone resorption and mild increase in the bone thickening, reduces the risk of vertebral fracture. Its adverse effects are hot flashes, leg cramps, and it is contraindicated in the patients with VTE. Teriparatide, that is, it is indicated in the severe osteoporosis, that is high risk fracture. Its mechanism of action is receptors on the osteoblast and renal tubule cells, also stimulate the intestinal absorption of calcium and phosphate. 135 amino terminal residues of parathyroid hormone given by daily subcutaneous injection. Its adverse effects are transient hypercalcemia, dizziness, nausea, headache. It's contraindicated in the Paget's disease due to potential osteosarcoma risk. Coming to denosumab, that is Prolia, it's indicated mainly in the postmenopausal women at risk of the fracture. Its mechanism of action is monoclonal IG. Monoclonal IG2 against inhibiting the binding of the rank and rankel like osteoprotogerin. It reduces the vertebral fracture by 68% and hip fracture by 40% and non-vertebral fracture by 20%. Subcutaneous injection should be given to
ಮತ್ತೆ ಇದು 1400 ಆಗ್ತೀನಿ ಅಡ್ಜಸ್ಟ್ಮೆಂಟ್ ಎಸ್ ಸರ್ ಅದು ವರ್ಕಿಂಗ್ ಆಗುತ್ತೆ ನಿಮ್ಗೆಲ್ಲ ನಮ್ಮ ಟೆಕ್ನಿಷಿಯನ್ ಏನಿದಾರಲ್ಲ ವಿಸಿಟ್ ಮಾಡಿ ಮನೆಗೆ ಫ್ರೀ ಡೆಮೋ ಇನ್ಸ್ಟಾಲೇಷನ್ ಇರುತ್ತೆ ಬಂದು ಯಾವ ತರ ಯೂಸ್ ಮಾಡ್ಬೇಕು ಅಂತ ಹೇಳ್ಕೊಟ್ಟು ಹೋಗ್ತಾರೆ ಸರ್ ಇದ್ರ ಜೊತೆ ಎಕ್ಸ್ಟೆಂಡೆಡ್ ವಾರಂಟಿ ಇರುತ್ತೆ ಸರ್
ಅದಕ್ಕೆ ಅಡಿಷನಲ್ ಇರುತ್ತಾ
ಏನ್ ಸರ್
ಎಕ್ಸ್ಟೆಂಡೆಡ್ ವಾರಂಟಿ ಅಡಿಷನಲ್ ಕಾಸ್ಟ್
ಎಸ್ ಸರ್ ಅಡಿಷನಲ್ ಕಾಸ್ಟ್ ಇರುತ್ತೆ ಸರ್ ಅದೊಂದು
now it is
ಹಲೋ
yes sir. Remesozumab is mainly indicated in postmenopausal women with history of osteoporotic fracture, multiple risk factors for the fracture, and who have failed or intolerance to other osteoporosis therapy. Its mechanism is like it humanized the monoclonal IG2 that activates the WNT pathway by bending the sclerostin, promotes the bone formation and inhibits the resorption. It reduces the new vertebral fracture by 73% through month 12 and by 75% through month 24. It's given subcutaneously. Its adverse effects are hyperostosis, cardiovascular events, osteoarthritis, and cancer, osteonecrosis of the jaw, and atypical femoral fracture. Complications: osteonecrosis of the jaw. is associated with IV biphosphonates, but not oral biphosphonates. Its incidence is very rare, and the treatment should be like stop intaking of the medicine such as biphosphonates and denosumab. Denosumab. Atypical subtrochanteric transverse stress fracture in patients with long-term biphosphonates. Its incidents are rare. It's due to extreme low bone turnover rates shown by reduced markers of the bone resorption. Example, urinary collagen type 1 across the linked N telepeptide. Its treatment is operative fixation with intramedullary nail, and medication should be stopped. Biphosphonate should be stopped. Thank you, sir. Sir, any questions? Sir, thank you, sir. So, any questions?
Yeah, you have discussed only the medical management of osteoporosis, isn't it?
Sir.
Hmm?
Yes, sir.
Surgical management you have not discussed.
Sir.
The management of complications, fractures, how to manage fractures, vertebral fractures. Hmm?
Yes, sir.
Okay, no problem. Okay.
Hello.
Sir.
Hello.
Sir.
Yeah. What about rickets and osteomalacia? You are not covered, no?
Yes, sir.
Did you tell something about rickets?
Yes, sir.
No. Is there types, diagnosis, manifestations, treatment?
Yes, sir. Relax, sir. Rickets and
Osteomalacia.
osteomalacia, relax, sir.
Yeah. Okay. And what should be the calcium?
It's Manjunath sir's topic.
Yeah. Now, when you are giving calcium supplements, which is better, whether it oxalate, citrate, carbonate form?
Oxalates.
And why? Anybody? With respect to absorption and its metabolism, which is the better form?
Oxalates. Read and answers.
Hello?
Where are the seniors? They should answer this question.
ಅವ್ರು ಯಾರು ಮೋಸ್ಟ್ಲಿ ಬಂದಿಲ್ಲ ಅನ್ಸ
Calcium
ಸರ್.
carbonate should be taken with the.
ಅಲ್ಲಿ ಹಾಲಲ್ಲಿ ಇರ್ಬೇಕ್ರಿ.
ಹಾ, ಯಾಕಂದ್ರೆ
ಅವರು ಅಲ್ಲೇ ಗೋಲ್ಡನ್ ಜೂಬ್ಲಿ ಹಾಲಲ್ಲಿ ಇರ್ಬೇಕು ಅವರು.
ಹೌದು.
ಅಲ್ಲಿದ್ದಾರೆ.
Khalid, how many people are there with you?
All PGs are here, sir. Second years and
Huh?
exam going. All PGs are here, sir. Second year and exam going. All PGs are here.
If you are not able to answer, other people should answer, na?
Let the others answer, no?
Switch on. 1 second, sir. I'll switch on the video. Sir.
Calcium oxalates are better absorbed than other calcium forms. Because
Loudly, loudly.
calcium oxalate will be in more ionized form and it will better absorbed than any other calcium product.
What about calcium citrate?
Even citrate will be available in ionized form, but oxalate is superior to citrate availability.
No, but normal calcium supplements will be in the form of carbonate or citrate?
Calcium carbonate, sir.
Calcium carbonate. So
Yes.
what is the, how much quantity is going to be absorbed? Effective calcium. You should read in detail, no? Daily we are prescribing,
Yes.
then you should know.
Yeah, Khalid, I think you have told, you have explained how much is absorbed in the gut. How many percentage of calcium will be absorbed?
40 to 70%
40 to
of
70.
the calcium will be absorbed.
40 to in all the forms, or more so in citrate form and compared to other supplements.
In oxalate, it will be 70%, sir. Whereas in citrate, it is only 40% is available.
Okay.
Yeah.
Thank you, sir. Sir, thank you, sir. Can you?
Okay. Hosangadi is there only?
Sir. Sir is here, sir.
Yeah.
Sir is here.
Is there any problem in network there? Sometimes
sir.
now the voice will fade off sometimes.
In the beginning,
Not every-
there is a problem, sir. But now it's good, sir.
Now it is okay. Now it is okay.
Yes, sir.
We had some problem in between. There was some fading of voice. Afterwards, it picked up. No problem. Okay.
Okay, sir. Thank you, sir.
Yeah. Okay. Right.
Okay, thank you.
I will check, sir.